In this lecture, we're going to be focusing on childhood shortness of breath and two common causes of both shortness of breath and cough, bronchiolitis and croup. This lecture refers frequently to the prior lecture, Introduction to Shortness of Breath, and how you approach a child with difficulty breathing from both history and physical exam standpoint. If you have any questions during this lecture, refer back to Introduction to Shortness of Breath. Our first case is a 9-month-old male coming in with both shortness of breath and cough, and this is him and his mother. Notice the way his abdomen is moving and the noise he's making. This is a child with bronchiolitis. Bronchiolitis is caused by a viral infection. Many viruses cause it, but RSV, or respiratory syncytial virus, is a common cause. The virus invades cells in the terminal bronchioles. This invasion causes edema, mucus, inflammation, and consequent bronchospasm. The disease goes away on its own, usually improving in 2 to 5 days. Think of bronchiolitis in a child younger than 2 who comes in with an upper respiratory illness, with wheezing, and increased respiratory effort. So what would you want to ask? Ask the general questions you'll ask in any child with a cold and shortness of breath. You'll also want to focus on a cough. If the child has it, ask what the cough sounds like and when it's worse. Ask about the child's overall health and how this illness is affecting its eating and hydration status. Conduct your physical exam just like always. First, watch the child. Keep them in a position of comfort. Then, auscultate the lungs. Going back to our case, this child is comfortable, but not moving very much. If you look at the belly, those are large subcostal retractions, showing a significant increased work of breathing. The child's also breathing much faster than a typical breathing rate at his age. Finally, the sound he's making is grunting, showing that he's needing to increase the pressure in his chest to keep open those small airways. This is a child we need to assist. When you auscultate, listen for all of these things. He does have the grunting you can hear in the video. Assess the rest of the body for related illness and findings of how sick this child is. So our case, the 9-month-old male. He was born a little bit early at 35 weeks, which puts him at a slight increased risk for severe lung infections. His vital signs: he has a fever at 38.6 degrees. He's tachycardic with a heart rate of 160. He's tachypnic, breathing too fast at a rate of 50. And he's hypoxic with an oxygen saturation of 89%. His blood pressure of 80/46 is okay, but it's not a great blood pressure, and so we'll be watching that carefully. On physical exam, when you go closer to see him, you note he has nasal flaring, the subcostal retractions that we saw, and the grunting we heard. Looking at his face, he has clear rhinorrhea, or runny nose, and his mouth is nice and moist, showing a normal hydration status. So even though he has this illness, he is able to eat and drink normally. On auscultation, you hear excellent air movement throughout the lungs, but he does have an end expiratory wheeze. On further history, the mom says that despite being a little bit early, he's a pretty healthy guy. His 4-year-old brother also has a cough and runny nose, but doesn't seem as sick as our patient. No one in the house smokes. Now think about what you want to do for the child and what your nurses could get to help you out. In him, his oxygen saturation is too low. It's less than 92%. So supplemental oxygen would be beneficial. Children, the younger they are, tend to be dependent on their nose to breathe. So bulb suctioning of the nose could significantly help. In bronchiolitis, both albuterol and adrenaline inhaled could be very helpful, and the dosages are listed. This helps open up those airways and allow an easier time breathing for the child. Finally, a chest radiograph will be helpful differentiating bronchiolitis from a few other diseases, which we'll talk about. So on your differential diagnosis is bronchiolitis, pneumonia, asthma, and congestive heart failure. They each have wheezing and cough, but otherwise they're pretty different. Bronchiolitis and pneumonia are the most similar. They both occur in a child who looks like he has an infectious cause of his symptoms. They have a runny nose, they have fever. In bronchiolitis, they tend to have wheezing in the lungs, whereas in pneumonia, they have rales. The chest x-ray is what really sets them apart. Bronchiolitis, the chest x-ray is predominantly clear, whereas in pneumonia, you'll have consolidation. Asthma, on the other hand, has wheezing in the lungs, but otherwise the child is healthy, is eating well, acting appropriately once they're able to breathe comfortably. This is a child who may have had wheezing before, again without other viral infections. Congestive heart failure appears similar on the surface, but learning more about the child, you can find the differences. So the child is also wheezing and might be coughing. When you listen to the lungs, you hear rales. However, this is a child who has difficulty feeding because they can't breathe and feed at the same time. They might get sweaty with the feeding or just refuse it altogether. Chest x-ray for a child with congestive heart failure may show cardiomegaly, or an abnormally large heart. On abdominal exam, the child may have a large liver, showing backup of blood and fluid. So let's go through an algorithm of approaching the child with wheezing. On the far left is the healthiest child. He has wheezing, but otherwise is breathing comfortably. Maybe a little nasal suctioning helps him breathe through the nose, but not much intervention is needed. He has clear lungs, and the parents need reassurance and may be able to be discharged home with some albuterol or just continued hydration. Our patient would fall more in the middle category. He had tachypnea and retractions. He had hypoxia and is going to need our assistance with oxygen and maybe some albuterol. This is when it's very important that we get the oxygen saturation as soon as the child arrives, so we know that he's hypoxic. Go ahead and give the oxygen. We can give him the albuterol and see how he does. We should recheck the child, again watching him, auscultating his lungs, and rechecking the pulse oximeter. Did our interventions help? How does he look now? Does he need repeat dosing? This child may be able to go home if they're looking much better. Otherwise, I would consider observing further or admitting. On the far right is our most sick category. This is a child with cyanosis, dehydration, severe work of breathing. This child's sick. They will need IV fluids, supplemental oxygen, nebulized albuterol and epinephrine, and potentially intubation. This is a child who will be closely monitored and admitted to the intensive care. Some common myths in children with difficulty breathing. The first is that children should not receive chest radiographs. Chest radiographs are very useful in children, and have a very low amount of radiation and are therefore safe and to be used when necessary. For us in this patient, it'll help us differentiate between bronchiolitis and pneumonia. The second is the need for an oxygen saturation. In this child, it was very helpful to know that the oxygen level was far too low and aggressive oxygen and treatments were necessary. Repeating the oxygen saturation will help us know how we're doing and if the child is improving. In summary, in children with shortness of breath, look for signs of respiratory distress and dehydration. In a child with a cold or upper respiratory infection and difficulty breathing, think about bronchiolitis. In a wheezing child, think about a chest x-ray to differentiate bronchiolitis from pneumonia. Bronchiolitis is caused by a virus, and no antibiotics are needed. To help the child's breathing, consider nasal suctioning, oxygen, inhaled albuterol or adrenaline as needed. In severe cases, you may need to intubate. Aggressive initial airway treatment may prevent subsequent intubation, so we should get on these kids as fast as we can to help them out.